Now we shift into a category of diagnostic evaluation for carbohydrate malabsorption. These tests are used when patients present with chronic bloating, diarrhea, gas, or suspected malabsorption syndromes. We'll focus first on D-xylose testing and then move into lactose intolerance testing and breath hydrogen testing. So the three primary assessment tools: a D-xylose test, which differentiates malabsorption from maldigestion; a lactose tolerance blood test, which assesses lactase deficiency; and a breath hydrogen or carbon dioxide test, which is used for specific carbohydrates intolerances. And remember, maldigestion comes from enzyme or pancreatic problems versus malabsorption is a small intestine mucosal pathology. The D-xylose test evaluates small intestine absorptive function, not pancreatic enzyme activity. After ingesting D-xylose, blood and urine are collected. If levels are low, it suggests mucosal damage, such as celiac disease or Crohn's disease. This is a high-yield exam concept because the test helps differentiate between pancreatic insufficiency, a problem of digestion, and bilious atrophy, a problem of absorption. This shows that approximately 50% of D-xylose is absorbed into systematic circulation and eventually excreted by the kidneys. Because excretion correlates with how much we absorb, urinary recovery is key to interpretation. So if the kidneys are impaired, this test may appear falsely abnormal. It's important, therefore, to consider any renal function or renal condition when interpreting these results. So we can see 50% absorbed, 25 into general circulation, 25 into the liver, and then 25% excreted via the kidney. So straight up 50% is automatically excreted. In normal adults, plasma concentration should exceed 20 milligrams per deciliter at the 2-hour mark, and urinary excretion should be at least 3.5 to 4 grams over 5 hours. If both blood and urine levels are low, the small intestine is not absorbing properly. If blood is normal and urine is low, think renal issues rather than malabsorption. This test evaluates both absorption and mucosal permeability, and it's often used when patients present with symptoms like chronic bloating, diarrhea, skin issues, food sensitivities, or suspected inflammatory bowel diseases. The concept is simple. A healthy gut selectively absorbs nutrients and prevents large or antigenic molecules from crossing. Increased permeability, leaky gut, allows large molecules into circulation, provoking immune reactions and inflammation. This slide lists common causes of increased gut permeability. This includes inflammation, dysbiosis, food sensitivities, NSAID use, alcohol, chemotherapy, and even HIV infection. Anything that irritates or inflames the mucosa can open up tight junctions. Clinically, this is why we often pair this test with stool microbiome analysis or food sensitivity panels, as this test identifies the result, and then we have to go back and determine the cause. This test does require a 12-hour fast. The patient collects a baseline urine sample and then drinks a measured solution containing lactulose and mannitol. These sugars are not metabolized and they act purely as markers. Over the next 6 hours, the patient collects urine. The amount of each sugar recovered reflects gut permeability and absorptive capacity. Mannitol is a small molecule that's normally well absorbed through the intact mucosa, so mannitol reflects absorption capacity, versus lactulose is a large disaccharide that should not easily pass through tight junctions, so lactulose reflects mucosal leakiness. Increased lactulose absorption indicates permeability, decreased mannitol indicates malabsorption of nutrients. In a healthy gut, mannitol is largely absorbed and lactulose remains unabsorbed. In a leaky gut scenario, both sugars appear in the urine at elevated levels. If permeability is increased, lactulose levels rise relative to mannitol. This will yield a high lactulose to mannitol ratio. If both are low, the small intestine isn't absorbing. Think villus atrophy or even severe mucosal damage. Here are some normal findings. Lactulose recovery 0.1 to 0.6%, mannitol 2 to 24.5, and the ratio is less than 0.05. A high ratio indicates Increased permeability, a low mannitol recovery, indicates impaired absorptive function. Remember, this test doesn't give a diagnosis, it just reveals that a dysfunction is occurring, and then we have to follow up with additional testing to determine the cause. So, looking at some kind of patterns that we could see, low lactulose, low mannitol would be malabsorption, like celiac, Crohn's disease, like a Crohn's flare, mucosal injury. High lactulose and high mannitol would consider leaky gut with increased permeability and excessive absorption of larger molecules. And then high lactulose, low mannitol would be permeability plus malabsorption. And these combinations guide treatment direction, repair, restore, remove triggers, and help to rebalance flora. When we come back, we will look at lactose intolerance testing.